Kicking off Module 6, we're going to move down the system and talk about ventricular arrhythmias. Before we get into that, let's talk about reentry versus automaticity. So reentry, this is an action potential wavefront, fails to extinguish instead of circulating around blocked areas. When we talked about our atrial flutter versus atrial fibrillation, that was kind of talking about our reentry circuits. We're going to go around and around and around and around. It's not extinguishing. It fails to extinguish. And so it's going to circulate around blocked areas and reactivate in the original excitation site. Associated with structural heart disease, it can lead to some life-threatening arrhythmias. Then we have automaticity. This is when our cardiac cells can spontaneously initiate an impulse without prior stimulation. We talked about this at the very beginning, right, of our whole module series. That's the beautiful thing about the heart, is any single cell in your heart is capable of automaticity. And that can be a beautiful thing if your heart is starting to fail. And it can be a very annoying, frustrating thing if you've got some cells that are misbehaving a little bit. Okay, so these can be caused by a normal mechanism like the SA node or an abnormal mechanism like your depolarized fibers. Alrighty, so premature ventricular contractions or PVCs. These can occur again for a number of reasons: diet, fatigue, stress, disease, ischemia. I feel like this is starting to sound like that little disclaimer you put at like a drug infomercial or something on TV, right? PVCs can occur when early electrical impulse occurs from a location in either ventricle. The early impulse causes early cardiac complex, which disrupts the rhythm. Cardiac complex has a change in morphology because of the different locus of stimulation. This is a bizarre QRS complex, aka I like to say it is an ugly backwards QRS. This can occur as a single PVC complex or in a pattern. So if we were to think about our heart here, and this is not going to be the best drawing, but we've kind of got the aorta that's going off there, and we've got this heart. Okay, so our normal QRS depolarization, right? We're going towards that apex, and this is the flow. We're going to go down and around town, right? We're going to start here, we're going to go down and around town. So if you suddenly had a signal that was like, hey, I'm going to start around over here. Well, in order to then have this is kickstarting it, it's got to go over and around and then down through the system. So it's like, whoa, all the way through. That's your PVC. It's this cell that's way at the bottom that's trying to start this cascade. And so it's got to go all the way around, and it's kind of funky and it's slow and it's backwards. It's not how it's supposed to go. Okay, that's your PVC. And we see that as it's depicted in our graph. So we take a look here. We've got our rhythm, and then, whoa, this funky thing right here. Okay, notice how this is pointing up here, and this guy's pointing down. So we're upside down. We're wide, right? We are wide, and we're kind of ugly looking. When you see big, ugly, wide, backwards, upside down, think of the PVC. That's all it is. And then again, if we kind of compare it to our PAC and our PJCs that we talked about, if you were to skew him on over just a little bit, you'd have a normal rhythm. But he's happening early, premature. That's all it is. It's a complex that originates in the ventricles, and it wanted to throw the party, and it just arrived early. PVCs happen all the time. Sometimes if you feel like your heart is skipping a beat, that's a PVC. We don't really worry about them most of the time. We want to identify them because, it looks funky, right? But we don't really worry about them unless they're happening so often that we are compromising, the integrity of our ability to meet physiologic demand. Okay, we have monomorphic ventricular tachycardia. Our morphological features here: no P wave, wide and bizarre QRS. Our rate is going to be greater than 100. Roughly 50% of the patients in VTach can become unconscious at the onset, and this is shockable with a defibrillator. Okay, so we look at our QRS complexes here. Let's see, our rate is very fast. Our rate is obviously tachycardic, and our QRS complexes are wide. Now, monomorphic just means that these all look the same. The shape of them, the morphology of them, they look the same. Versus polymorphic, same sort of, things, but our shape changes. These guys here don't look like those guys over there. So because of the changing shape, we call it a polymorphic or morphology, multiple different morphologies, polymorphic ventricular tachycardia. All right, then we have torsades and VFib. Now torsades or torsade de pois, whichever you prefer. This is twisting of the points. Morphological features here, no P wave. We're going to twist that QRS complex around an isoelectric line. This creates our ribbon pattern. You'll see that a lot. Rate is going to be greater than 100 beats per minute, prolonged QT interval, and this is shockable with a defibrillator. And here's a couple examples. Take note here, we've got this ribbon pattern that happens, right? That's our ribbon pattern, a twisting of the points, torsade de pois or torsades. Then we have our ventricular fibrillation or VFib. Morphological features here, no P wave, no QRS complexes really. It presents with a chaotic waveform which reflects the electrical chaos that is occurring within the heart. The heart is not actually beating as we know it. The rapid, disorganized electrical activity actually makes the heart appear to quiver. Some have described this, as shaking like jello. If you imagine this guy just kind of shaking around a little bit. This is a life-threatening dysrhythmia, which requires immediate, effective, and aggressive care, and it is, like our others, shockable with a defibrillator. So remember back when we talked about AFib? AFib was a bunch of kindergartners being let into the classroom, they're ringing the bells. This is the same thing, except we're in the ventricles now. So you got a bunch of, kindergartners let loose in the ventricles, and they're ring-a-ding-dinging all over the place, and nothing's coordinated, it is an emergency situation, and you need to establish control. So shockable rhythm, VFib, we've got this chaotic waveform happen. And we can have a coarse wave where the waves appear larger. You can kind of make out like one wave from the next, but not really. We're not going to measure any intervals here. Versus our fine fibrillatory waves where we're just going to see that chaotic line. Alrighty. And that brings us to the end of the ventricle arrhythmias that we're going to talk about here. Stay tuned. We're going to talk about more. Leave it in the comments if you have topics that you want to go through that are not covered yet. Happy to make more of these. Best of luck in your studying. Take care.